stream on YouTube as well. And we will be, therefore the meeting will be available for viewers that are not logging into Zoom. So please feel free to share the link and the information with your friends so that they can also join the live stream. For everyone who is joining us, today is a beautiful day. There's lots of snow where I am. I'm literally just in from shoveling, but that will probably not mean anything for people in Pakistan and Bangladesh. So we will move on because we have a really exciting webinar today where we actually hear about the progress in PPM in both in Bangladesh and in Pakistan, and a lot has happened in both countries. We know that there have been recently joint monitoring reviews, and where we like to zoom in today is about the private sector engagement and specifically private provider engagement in both of those countries, and hear from country experts about what has been seen as progress and what are some recommendations for the countries to take their work forward. So to our participants and everyone who's online, please use the Q&A. That's the best place where you can be posting your questions. We will be asking our panelists to share the questions, to share answers in the Q&A as well, and we will pick up live questions during the Q&A session. So with me today on this panel, I have four fantastic speakers, and I will be for Pakistan, we have Aamna Rashid, who is the lead of the tuberculosis activities in Mercy Corps, and she has a background as a medical professional. She also works as a gender lead in the country in the program, and she's coordinating many projects on private sector engagements in the country. She will be talking in response to the recommendations from the Joint Monitoring Mission, which will be presented by Guy Stallworthy, who is the private provider engagement lead, the global lead in the Bill and Melinda Gates Foundation, and I think many of you know him. Guy was part of the mission in Pakistan and will be presenting what the recommendations are. As for Bangladesh, we have two fantastic speakers today. First of all, we have Anupama Hazarika. Sorry, Anupama. She's in Bangladesh. She's the lead on communicable diseases in the World Health Organization office in Bangladesh. And she has a fantastic background with 20 years of experiences in global health in various organizations. And she will be talking about organizing the mission in Bangladesh and presenting the recommendations and the situation on TB and PPM in Bangladesh, which will be followed by Dr. Akramul Islam, who is the director of communicable diseases in BRAC. He also is currently leading many other programs in BRAC, which is a large organization that is working on private provider engagements in the country. And we look forward to hear his responses to the recommendations from Bangladesh. So this is the panel, and I cannot wait to hear their input and their presentations. And with that, I would really appreciate to hand the floor over first to Guy Stallworthy. We're starting with Pakistan. And so I'm looking, Guy, are you going to share your slides directly?
Petra, I just sent them to you. It might be easier if you do from my side, if that's okay.
I don't have them yet, Guy. We could also start with Bangladesh if
is it showing my no?
We can see that you're starting to share the screen, Guy. Let's
sharing.
I can see your slides, Guy. Maybe if you can put them in presentation mode, perfect. And there's one funny button that we can see. Give subtitles a try.
How's that?
Now it's perfect. Excellent. Okay, floor is yours.
Great, thank you very much. Greetings to everybody. Great to be connected in the new year, as Petra said. So I'm going to present the findings of the Joint Program Review Mission to Pakistan, which took place in November of last year, where I was a team member focusing on public-private mix. And just to give ourselves the context, Pakistan, of course, is the high-burden country. It's number 5, I believe, in the world in incidence, with around more than 600,000 deaths. In 2021, the program notified of 340,000 TB patients. That's about 55%. So that's just to give some context. I won't go into that much further. I want to really get into the PPM issue. This is a country, as many in Asia, high-burden countries with really dominant private healthcare sectors. Estimates of well over 75–80% of early care seeking taking place in the private sector. 100,000 GPs, possibly 5,000 hospitals, more than 66,000 private pharmacies. And there was a study and an analysis of TB drug sales data in 2018 that suggested as many as 164,000 patients at that time may be purchasing their drugs in the private market. Of course, there's a lot of uncertainty around that estimate, but just to say that there's a very substantial private market for TB treatment as well. In some ways, Pakistan has got the strongest, in my view, engagement of private healthcare providers amongst the high-burden countries. It's been supported by the Global Fund consistently since 2005. There's some very strong NGO, 8 or 9 of them, that have been working on TB for many years that are very effective. When I say that perhaps the strongest in private provider engagement, I'm referring to the percent of estimated incident patients who are properly managed by private healthcare providers under program protocols, which may have reached 19% or so in last year. Currently, there's a Global Fund support of around $30 million over 3 years being implemented by 7 NGOs. The principal recipient is Mercy Corps, but the work is done by Mercy Corps and 6 other NGOs who do the actual work on the ground. Between them, they have over 700 field staff, and they're covering almost most of the country, as Aamna would be able to describe. Building on success over many years, the current Global Fund grant has extremely ambitious targets about increases in case finding and GPs engaged. We in the Gates Foundation last year contributed about $5 million to the same NGOs to help them to reach those ambitious targets by developing their digital TB management systems, especially around DHIS2 tracker, which would be for national purposes, but our support is focusing on the PPM use cases. Just the context of who's doing what and what the efforts are. The recent achievements have been really very, very impressive. As this chart shows, the big growth has been in contributions by GPs, which I think is particularly interesting because primary care, they are early in the patient's care pathway, and steady contributions by other NGO hospitals, private hospitals, and by non-engaged public. In fact, at the very latest figures, this PPM is contributing 46% of the latest case finding, from especially around 6,000 GPs, and that number of GPs engaged has doubled in recent years. And the treatment success rate is very good. Unlike some other contexts, this is the place where nearly all of these notified patients in the private sector are provided TB treatment, program-supported drugs. And as you can see, the DST coverage has reached 59%. Lately, Mercy Corps and its partners have been deploying sample transportation networks at scale, and there's very limited placement of gene experts in private facilities, but when they are placed in private facilities, the utilization rate is nearly double what it is in the public sector. Recently, Dopasi with TB Reach funding, that's another NGO, demonstrated proof of concept of a very interesting additional approach, which is to capture prescription drug sales in the private sector from pharmacies. And in just 4 districts over 1 year, they were able to notify well over 15,000 patients from nearly 3,000 pharmacies. So that was a very promising new approach that could be scaled up. And as I said, they're piloting the use of DHIS2 tracker. And there's really quite a nice cooperation between the NTP and the NGOs. So the challenges, I've just got 2 slides really now, one on challenges. The first is there's still very limited access to expert testing for privately managed patients. There's only 11% molecular diagnosis, molecular testing at time of diagnosis, which compares with 55% overall. So it's much better than the public sector. And there's continued low bacteriological positivity around 38, which is also lower than the public sector. One of the challenges is the Global Fund budget arrangements don't give the NGOs a lot of flexibility for adjusting their activities and with experience, and that's been a bit of a constraint. For example, increasing the rates paid to sample transport agents, and also the incentives that are available. They haven't changed since 2014, and as you can see, the incentive to a private doctor is now just less than $2 per TB patient. The task not better the resources more efficient, maybe thing resident to other users. In particular, is fine. So 1 million to the NGO, not about engagement. I think it's more than a fifth of it is dedicated to active case finding activities with chest camps, many of which use symptom screening and sputum microscopy, which is of course extremely inefficient. Others, they have 30 or 40 vans with digital chest X-ray and gene expert, which of course are much more effective. And they've also deployed recently screeners in private hospitals. But there must be something, this on the face of it should be an efficient activity, but they're only finding about 6 TB patients per month per hospital. So that's something that needs attention, because that it should be much higher in our view. So we made 10 recommendations. The first was that the program should continue to scale up the engagement of GPs and hospitals in particular, with an emphasis on the GPs because of early case finding. They really need to do a lot to increase private patients' access to modern diagnostics. There should be more expert machines placed in private facilities because they get a much better utilization rate. There should be more contracting of private lab networks, both for in some cases where they have molecular diagnosis, but also for their sample transport, and that sample transport needs to be massively scaled up. We really strongly recommended that they discontinue these conventional case finding camps, because we showed the numbers that they could find many, many more patients by deploying the same people and resources to GP engagement. And therefore they really needed to think about the incremental gains of the different activities and allocate their resources for maximum impact. We felt that this Stopasi pilot project merited a very rapid, aggressive scale up to capture TB prescription sales, and then support those patients and reach out to those doctors. And that this would require some flexibility, some adaptation by these NGOs that have been implementing a fairly standard model for a number of years. The digital systems would be need to be implemented as planned and taken to scale. Both the Global Fund and the NGOs should work together to improve the budget flexibility. Maybe the NGOs need to present their requests more clearly, but the Global Fund also needs to respond more quickly so that they can adjust their activities according to experience. We felt that this value of incentives should be restored, This may be a somewhat controversial recommendation in some quarters in Pakistan, but it clearly private providers deserve to be compensated for their work for TB patients. And it's better that this comes from the program than that it comes from the TB patients themselves. There's some interest in exploring private provider role in decentralization of DR-TB treatment. We recommended some areas of some operational research, in particular on how to improve the targeting of the remaining ACF camps and standardized patients and patient pathways in order to better understand the market. And then finally, Petra, there was discussion of the learning network, and there's a lot of interest in establishing perhaps a national chapter of the PPM learning network to even further improve the learning and the coordination amongst the various stakeholders. I'll stop there. I hope I didn't exceed the time. Back to you, Petra.
Really interesting. Thank you so much, Guy. This is a great start and wonderful to see the recommendation and the fantastic progress. I'm really happy to hand over to Aamna. And Guy, if you can stop sharing your screen, then we can ask Aamna to share her presentation to give us some of the pictures that Mercy Corps is doing and basically a response to these recommendations from the country level.
Yeah, thank you very much, Petra. So can you confirm if you can see my screen?
Yes, we can see it. Can you put it in presentation mode in the little button? Sure. Thank you. Wonderful.
All right. So, hello, everyone. And thank you very much, Petra, for inviting me for this very important webinar. And thank you very much, Guy, for sharing the key recommendations from the Pakistan Joint Program Review Mission. So the couple of few slides, the first 2 to 3 slides will cover more or less the same information that Guy has already shared. So I'm not going to spend more time on it. But just to give you an overall overview that in Pakistan, with the support of the Global Fund current grant, we are implementing this TB program across the country in more than 120 districts. Mercy Corps is implementing this grant with the support of 6 implementing partners, but there are additional private sector partners as well in the country who are contributing to the TB case notification, but they are directly reporting to the national or provincial TB control programs. So with our aim with this current Global Fund grant is to reach more than 400,000 TB patients. And there are a number of districts where Mercy Corps as a principal recipient is also implementing directly the TB program in the country. The private sector started working in PPM in Pakistan back in 2005. Then in 2007, we implemented a countrywide advocacy, communication, and social mobilization activity. In 2010, there was a huge scale-up of public-private mixed intervention or a program with 2 basic objectives. One was to increase the case detection through engagement of private healthcare providers, because in Pakistan, for more than 80% of the population, their first point of contact is the private provider. So it's very important to engage the private sector in the country. And second was to enhance public and private sector coordination and collaboration. In 2018, and during this 2010, when we started this PPM, the major focus was on the engagement of the solo GPs or clinics. Going forward in 2018, there was an expansion of PPM, and there were certain innovations that were incorporated in the PPM program. So, for example, we started implementing the mobile screening camps with the use of mobile vans, which are equipped with digital X-ray machines, and some of them also have the expert testing facility. Then we also engaged lady health workers. Lady health workers in Pakistan are the frontline community health workers who have access to the household members in the community, and by engaging these community health workers, we saw a very significant additionality in the TB case notification in the areas where they were engaged. In addition to the solo clinics and private providers, we also engaged large private hospitals. And with the passage of time, we have seen excellent contribution of these private hospitals in overall TB case notification in the country. We also initiated our specimen transportation model in 2018. This is an online model where an online application is being used. The community volunteer riders are engaged and they get registered through that online application. The purpose is to support the communities to have access to the latest diagnostic technology. So basically, these riders, they transport sputum samples either from the basic health units or rural health centers of the public sector, or from the private sector laboratories or private healthcare providers, clinics, to the expert testing facility. Then recently in 2021, with the new grant of the Global Fund, we were able to have a countrywide scale up of the PPM program. And it was not only a geographical spread, but also we increased the number of providers from 4,000 to almost 15,000. The number of hospitals were also increased. We also expanded our specimen transportation model in additional districts. And we also incorporated our expert machines in the private sector. Initially, they were only in the mobile vans, but now we have around 28 static expert machines in the private sector. And also we introduced the preventive TB treatment. Now, this slide is just to give you an overview of the overall contribution that private sector is making in the country. The data is still 2021, and in 2022, the figure is a little more higher, but you can see that in 2017, the private sector's contribution in the overall TB case notification was 32%, whereas in 2021, it rose up to 41%. And now coming to this country response to the JPRM recommendations, so Guy has already mentioned in detail that what recommendations were made by the JPRM, and I'm very pleased to share that the country has incorporated almost all the recommendations made by the JPRM in their national and provincial strategic plans. So we are in the process currently in finalizing those plans, but all of these recommendations that you can see on my slide have already been incorporated in those strategic plans. So there has been a consensus at the national and provincial level for the scaling up of the engagement of private providers. The one additional thing that we have included is the engagement of the informal healthcare providers that were not previously engaged in our current PPM program, and these are basically for the referral of the TB presumptive cases. Similarly, we will be scaling up the intervention of the large private hospitals where we place TB screeners, and they are responsible to verbally screen the OPD and identifying the TB presumptive and then referring them to the trained providers within that facility. And within these large private hospitals, we have set up, in some of them, we have set up our expert testing sites, and we are also in process of establishing the static X-ray sites in these hospitals. So basically establishing a center of excellence where patient can get all the facilities, including expert X-ray and microscopy. Then implementation or the scaling up of molecular testing in private sector, as Guy has already mentioned. So I think there is a consensus at the national and provincial level that there is a need that private sector should have more expert testing facilities. There are facilities in the public sector where the expert testing sites are underutilized. So either those expert testing machines or expert machines needs to be strategically placed in the private sector, or additional expert machines needs to be procured and placed in the private sector to improve the access of the patients who are visiting the private sector. Similarly, the implementation of specimen transportation model in full potential, another JPRM recommendation which we have incorporated in the plan, and all the across the country we will be implementing this project. Active case finding, definitely we are going to scale up this active case finding. One of the recommendations by the JPRM was to make sure that we identify the hotspots, the areas where that we identify for conducting these chest camps through the use of artificial intelligence-based geospatial targeting. So we are already implementing and using this AI-based geospatial targeting with the support of KIT Tropical Institute and National TB Control Program. And we have seen that the hotspots that we identify with the support of this AI, their yield is doubled as compared to those chest camps where the hotspots are identified manually. So that's why there is a consensus that we are going to use this technology. However, we also know that there are certain areas where, due to security restrictions, we may not be able to use artificial intelligence. So for that, we'll have to come up with a different strategy, or we can continue using the manual method of identifying the hotspots. As Guy mentioned, that the conventional chest camps that we were conducting, their yield was very less. So based on the recommendation from the JPRM, now what we have proposed in the strategic plans is to convert these conventional chest camps into X-ray screening camps. So we will be using portable X-ray machines in these camps, especially in urban slums, in prisons, and there are many areas in the country where the mobile van cannot go because of the poor infrastructure, because of the security reasons, or many other reasons. So instead of completely discontinuing those camps, we are just converting them into X-ray screening camps. We are also focusing on focused intervention for TB HIV. We know that one of the targets for the private sector and for the country is that all the registered TB patients should get registered for should be tested for HIV. So at the moment, we do not have any focused intervention, but going forward, we think that this will be very, very important. We have also proposed, based on the JPRM recommendations, to integrate TB in MNCH and nutrition. Similarly, TB diabetes bidirectional screening is something that we would like to continue. We have done a small pilot in one of the provinces, and the results are very promising. So we would like to continue this in large hospitals, especially. Guy has talked about the pharmacy intervention, so definitely we are going to scale up. This intervention will actually help us in tracking back to those providers who are not part of the system, but they are dealing with the TB patients. We would like to engage them in our PPM network so that they can start notifying the cases in the system. Digitalization, as Guy has said, so with the support of Bill and Melinda Gates Foundation, the private sector data will be digitalized and it will be linked with DHIS2 tracker being implemented by National TB Control Program. Private providers needs to be incentivized. There has been a lot of discussion around this, even after the recommendation which has been made by JPRM, although we were able to incorporate it in the provincial strategic plans, but still there are two different opinions which are being, we have heard during the interventions, but I think the data of the providers which are contributing more than 80% of the case notification in the country, and the data from the countries like Nepal and India that Guy has mentioned, we think that it is very important that these providers are being incentivized, and these are all performance-based incentives. So we also are establishing provincial PPM technical working groups at each province that will actually help us in addressing different technical matters like preventive treatment, implementation of mandatory TB case notification, etc. And we are very happy to share that there is a consensus at the national level that we should establish a PPM Learning Network Pakistan chapter, and we are hopeful that this activity will also be part of our next global funding grant. There are some research activities that we have included in JPRM. Guy has already talked about it, so I'm not going to repeat it again. Then there are certain community mobilization activities. We have also incorporated engagement of community health workers in the uncovered areas. So there are areas of around 40% of the districts in the country are uncovered by any type of healthcare worker. So we think that it's very important that we need to engage healthcare workers in those areas to identify missing TB cases. There is a need for advocacy for preventive treatment. At the moment, we are facing lots of challenges in terms of implementation of preventive therapy. So it's very important that advocacy should be started from the professional bodies, engaging the health regulatory associations and pulmonologists and other key stakeholders so that they can advocate and they can actually help us in implementing this. The last point that I would like to mention here is the management of MDR TB cases in the private sector. This is still although it is one of the recommendations by the JPRN, but we have been hearing in different discussions that the private sector should not get itself engaged in the management of or in the decentralized MDR TB. So this is something on which the discussion is still going on. And we really hope one of the recommendations that we made as a country, as a private sector partner, was to at least pilot test this in few of the large hospitals where different types of facilities are already available. And let's see if private sector in the large hospitals is able to manage the MDR TB patients. So I'll just stop here and over to you, Petra. Thank you.
Thank you so much, Aamna. That's a wealth of information and activities, and really impressive to hear your points. I would like to ask any of the attendees or any of the panelists if there are questions. We have a few minutes for questions, but I didn't see anything. I see a few questions in the Q&A actually. So Aamna, maybe you talked about the TPT implementation having some challenges. Can you elaborate a little bit on that? And the second question is, what are the methods that you use to engage general practitioners? What are their enabling factors? Is there any reward or punishment for them? Thank you. And the first question was from Firdaus Wahid, and the second question by Aditya Wicaksono from Indonesia. Aamna, do you want to start first, and then maybe Guy can chip in?
Yeah. Thank you very much, Petra. So responding to the first question from Firdaus about the challenges in TPT implementation, I think the biggest challenge to begin with was the availability of the medicines, their distribution at the district level, and then the availability of the guidelines at the national level. So I think the development of the national guidelines for the implementation of TPT was one of the biggest challenges since the beginning of the grant, and the guidelines were developed there was a huge delay in the development of the guidelines, although they are now there. In addition to that, we have faced lots of resistance from the private healthcare providers. They are very much reluctant to provide these medicines to the patient, to the household members of the registered patients. We also conducted a barrier analysis for preventive treatment in order to understand that what are the barriers that are actually blocking the initiation of TPT among the community members. So one of the reasons that we found out was that people think that if they start taking TB medicines, they will be stigmatized as the TB patient is stigmatized. So stigma was one of the reasons. Then people were also afraid of the side effects of the medicines. So there were multiple reasons why. So there are, at different level, there are barriers. The barriers at the part of the private healthcare provider, the barrier at the part of the people who have to take these medicines, and then actual implementation of the guidelines and availability of the medicine. At the moment, there is split dose medicine, whereas the requirement is for the fixed dose. So that's another challenge that we faced. And for that, we have now developed a complete action plan. So first of all, the guidelines were developed at the national level, followed by the availability of the medicines. And now we are actually conducting few advocacy-related activities at the national and provincial level to engage key stakeholders who can actually advocate for the importance of TPT, followed by some roundtable meetings or advocacy meetings at the district level with the pulmonologist and those key stakeholders that can take this agenda forward and can convince the private providers that why this is important. So I hope I was able to respond to this. Coming to the second question, which was by Aditya. So how we engage the general providers is basically that in a particular geographical location where we have to engage the providers, we conduct a mapping exercise to see that how many actual number of private providers are based in that particular district or area. And then we have developed a certain criteria. Based on that, we identify those providers. We sign an MOU with them, a memorandum of understanding. The 2 or 3 major criteria are that the general provider must join the training on the national TB case management guidelines, and followed by following those guidelines and taking part in our quarterly review meetings, for example. So there are certain criteria that they have to follow. In terms of incentives, yes, we provide them a small incentive of around $2 or maybe less than $2 against each case that get registered at their health facility. And no, there is no punishment, but I mean, in initial grant, when we were used to engage them, if in a year or the 4 quarters they were unable to register a case, we used to drop them, and then we find out a replacement and engage them. So this is how we engage this. So I'll just stop here, and maybe Guy would like to add something. Thank you.
Guy, do you want to add for maybe a short minute? I see there are 2 more questions.
Yes, I'll do so. I want to add briefly to 2 questions. I was typing furiously, but I'm not very quick. So Aditya, I think the key has been the deployment of a large number of very well managed field staff. So it's old-fashioned boots on the ground relationship management. And the interesting thing for us was that to go to further scale, and let's remember there are still a long way to go in Pakistan, it's going to need digital technologies. If I remember correctly, each field worker was engaging, Aamna can correct me, maybe 15 or 20 providers. But in other countries, a field worker can engage 30 or 40 providers and all the patients effectively by using digital technologies. So the interesting challenge facing the NGOs is how to go to much greater scale without multiplying necessarily the field force. And in terms of Elizabeth's question about key factors that may or may not be replicable, I would argue that it's the sustained support to professional, well-managed NGOs who've built a capacity here. It's 7, 8, 9, 10 of them over 15 years to do this job well. It's not dependent on one organization. And between 10 or 15 NGOs, you can really cover a large country like Pakistan and do an effective job. But you need sustained support, and I credit the Global Fund for having put that in. Of course, you need a supportive government that's willing to work with those NGOs once they're funded. I'll stop there.
Thank you so much, Guy. And I think that's a beautiful transition to go from Pakistan to Bangladesh. And I would like to ask Anupama to get ready to present. In the meantime, I see Firdaus, you had another question in the chat. I would like to ask Aamna maybe to look at the question in the chat, in the Q&A, and respond it, type in the answer in the response. People, please keep putting the questions in the Q&A. We will ask the panelists to answer in the Q&A directly, and we might have a little bit of time at the end of the presentation to go to more generic questions. But for now, I would like to hand over to Anupama, and we're going to listen to the situation in Bangladesh. Anupama, the floor is yours.
Greetings, colleagues. This is such a good opportunity for us to connect with all the august audience around the world. And thank you so much for having us over here. Very quickly going into the presentation itself. Next slide, please. The contents of this presentation, I would quickly touch upon the country context, the TB in Bangladesh, public-private mix, TB-JMM observations. Next, please. So bringing you all into context, Bangladesh is one of the most populous countries in the world. There is a land area of 150,000 square kilometers and a population of 165 million. The country essentially is divided into 8 divisions, and these are further divided into 64 districts, which are also known as the Zilas. And then there are 492 sub-districts, and these are known as Upazilas. There are 4 metropolitan cities and 12 city corporations, and these are further divided into unions and wards. Just to bring the social determinants of health, you can see that the drinking water access, toilet, and electricity are all at 98%, so it's very good. Now, for the comorbidities, the NCD death rate is 398 to 503.7 per 100,000 cases. And deaths due to mental health disorders is 16.8%, which is mostly due to depression. The BCG coverage is almost 100% in the country. Next, please. The healthcare system essentially has the public sector, the medical colleges in the private sector, and NGO and other sectors such as corporate and armed forces. The public sector is very, very strong, and the network is right from the national level, where you have very specialized institutions, to the ward level, where there are very strong community clinics for community engagement. Now, there are 106 medical colleges, both public and private, and there are also 6 armed forces medical colleges. Besides this, there are private hospitals, diagnostic centers, and private clinics. They also have a very robust network of NGOs. Next, please. Now, if I dive deeper into the private sector, the total number of registered private hospitals and clinics and the diagnostic center is about 14,850. Now, the demographic health surveys have estimated that 60% of the health facilities are private and 84% of those seeking initial care is in the private sector. Many of the clients seek repeated treatment from the informal sector, thus delaying diagnosis, and there is no known sale of TB drugs in the private sector. Next, please. Just to bring you into the context of the TB burden itself in Bangladesh, the Global TB Report 2022, according to the Global TB Report, there is an incidence rate of 370,000 cases with a confidence interval of 273 to 493,000. The HIV incidence, rather prevalence, is very low in Bangladesh. It is estimated that there are only 14,000 cases. And if you can see, that reflects into this indicator, which is TB HIV incidence is only 730. MDR or RRTB incidence is estimated to be 4,500 cases, out of which 1% is from the new cases and 4.8% from previously treated cases. HIV negative TB mortality is 42,000 and HIV positive TB mortality is 170. Next, please. Now, as you can see, for the last 20 years, the incidence has been increasing, and the HIV negative mortality rates have been declining. In 2020, the country reached the NTB targets, and it has continued to retain that. Next, please. As for the TB case notification, it is also going up. As I mentioned previously, that the TB notification, the estimated number of TB incidents is 375, and somewhere in the mid zone, there is the TB case notification, 307,000 cases, with a treatment coverage of 82%. Now, you will see a slight fall, a slight dip in cases in 2020, and this was due to COVID. If we dive deeper, it happened in the second quarter of 2020 when the COVID pandemic hit Bangladesh, and then it rapidly rebounded to its original case notification rates. And this has been exemplary for the health system in Bangladesh and all the NGOs who've been working very hard during that time, and has been recognized globally. Next, please. According to there are regulatory aspects also, and one thing is the mandatory notifications of 2014. TB is a mandatory notifiable disease. It is applicable for all forms of TB and applicable to both public and private sector. And to support this, next please, the government, along with partners, USAID and others, have developed a mandatory notification app, and the field trial for this app started in 2019, and currently it is operational in Dhaka Metro and Rajshahi Division, involving center personnel and private practitioners. So they are rolling it out very rapidly across the country very soon. Next, please. So regarding the public-private mix in the country, next, please. So the NTP basically has strategized and with the help of various partners implemented a patient-centered care with countrywide coverage to ensure access to all. This is integrated with the general health services at all levels, and there is a very robust community engagement. The partnership approach, which is the GO-NGO, exists up to the community level, and diagnosis and treatment of TB are free of cost. Next, please. As you can see from the map on the right of your screen, the NTP works very closely with all the partners, and the partner institutions cover the entire Bangladesh. There is diverse partnerships. There are the NGO consortium, civil society, medical college hospitals, specialized hospitals and institutions, development partners, professional associations, and corporate sector. The World Health Organization is very proud to support the government of Bangladesh and the National TB program in all its efforts. Next, please. For the public-private partners, if we dive deeper into the private sector, we can see that there are almost nearly 80,000 graduate private practitioners who are engaged with the program. Over 500,000 non-graduate private practitioners. There are 37 medical colleges, public medical colleges, and 78 private medical colleges. Almost 85% of the registered private clinics, hospitals, and diagnostic centers are already engaged in the program. The NTP works very closely with corporate sectors such as the Bangladesh Garment Manufacturers and Export Association, Bangladesh Knitwear Manufacturers and Export Association, and the social marketing company. The government health programs we have the NTP is working very closely with the NCDC program, the National Nutrition Program, and maternal and child health programs. And they also work with 29 NGOs to reach out to all the community. Next, please. So if we see the referral sources for the patients notified in 2021, nearly 70% has come from this public-private mix. And the private sector itself has contributed 25% of the referrals. Maximum, almost 80% of that comes from the graduate private providers. And this is a bit of a selective referral, but then they contribute majorly to the overall referral scenario of Bangladesh. If we see the same divisions, then we can see that the maximum cases after the Swasthya Sevikas and the non-government field staff are the graduate private providers and the government hospitals. You see that dip, which is the 2020 dip, which has happened. There was a robust engagement of village doctors. You can see it here as VD, village doctors previously, but that engagement is slowly declining and needs to be revamped. Next, please. So for the engagement of the graduate private medical practitioners, the government has encouraged, the national program has encouraged the referral of patients with presumptive symptoms to the NTP DOTS facility for diagnosis and treatment. They also closely work with medical associations for sensitizing different medical colleges to disseminate information about TB. And as I mentioned before, the Janao app is for the easy referral for patients to the DOT centers by GPP. And over time, almost more than 50,000 cases have been referred by these GPPs to the national program. Next, please.
Anupama,
Yes,
can you
please.
go a little faster in
Yeah,
interest of time?
Another 5 minutes, please. Yes. So the NTP also works very closely with the workplaces. They have close association, as I mentioned before, with the garment factories, and BRAC will speak more about that. Next, please. And the NTP also has a prison program where they screen all the prisoners over time. There are a total of 68 prisons, out of which 52 prisons currently report through the NGO partners and rest from the government facilities. Next, please. The JMM observations for 2022 are as follows. Next, please. So the JMM basically have identified challenges in governance, the quantity of services, quality of services, and the health systems. So they have recommended, next, please. They have recommended basically for governance, the need for a more decentralized PPM planning, implementation, and oversight at the regional and local level. For the quantity, they have recommended quantification of the PPM National Strategic Plan to expand the non-graduate private practitioners, to expand the TB diagnostic services and add DOTS corner to the large private hospitals and other large volume hospitals that do not have a DOTS corner. To increase the quality, expand the ICF, especially in high volume hospitals, and increase diagnostic capacity and strengthen the existing models which are there. And also the overall health system tools to increase and new mobile technologies, to introduce new mobile technologies, and also to keep the conversation about the strategic purchasing going. Next, please. These are the references. I would acknowledge my colleagues, Dr. Afzarul Rahman, the NTP Program Manager, and Dr. Nazis Arifin for helping me out with these slides. Thank you so much.
Thank you for this really great overview. And I would like to ask Dr. Akramul Islam to please follow up, because we would be loving to hear the presentation from BRAC in response to Dr. Hazarika's presentation. Thank you. Go ahead, Akram.
Yeah. So can you see that my presentation? Yeah?
Yes, we can. Can you put it on presentation mode?
Yeah.
Thank you.
Okay. So hello everyone. As Anupama was presenting the Bangladesh case, and he clearly mentioned that the role of NGOs in TB program in Bangladesh, and you have seen this map that NGOs supporting national programs throughout the country, and BRAC itself basically providing support to nearly 2/3 of the countries. So if you see there are 500 sub-districts, we're covering around 320 plus sub-districts. So that means around 60% to 65% population is under the BRAC supported areas. So it's quite a big coverage. But I will just not going on that part, but I will mostly focus on my presentation on the private for-profit sector's engagement. And to making this engagement, BRAC's dedicated established around 62 diagnostic centers, which is closely linked with the private sectors, or the referring from there, for supports and care. We've also established more than 66 TB centers in the medical schools. Anupama was telling that more than 100 medical colleges we have it, and around 77, DOS corner in this medical colleges was covered large by BRAC. We have 4 bands, which covers both peri-urbans as well as the Rohingya population in the Cox's Bazar. So, peri-urban areas as well as the pre-zones and other slums as well, they covered the mobile bands. So what, if you look into the hospital, DOS corner, particularly this is the area that we work closely with either private or the public medical college hospitals. So that is a both mix it up. And this dot centers are basically is located in the outdoor, and there is stopping supported through our channel, and then they refer this, any presumptive coming from this OPD or refer from any of the doctors, they just directly link with the laboratory services. So their role is mostly with the linking from OPD to the laboratory services, and once the diagnosis happen, they linked again with the treatment sites closest to the home. So this is their function is to avoid any missing cases which are diagnosed both medical colleges, private or public sectors. And the second part is our intervention is TB diagnostic centers, mostly in the big cities and the large towns. And then the primary objective is to the refer TB presumptives who are sputum negative but require extra supports. So they have been linked either directly from the peripheral level or through the private sector level. So we also connect with the private sector. They can send here because these centers are freely they're making the free tests. This center is now also equipped with gene experts and COVID test facilities as well as HIV test facilities are there. So it's kind of, this center is kind of a multiple facilities, test facilities are there, so they can avail free of cost, either coming from the doctors or coming from the peripheral level. So this is the one way of attracting people in many places, particularly in the lower income settings groups. The next part is we've also, our field staff will also connect with the private sector providers in the afternoon or in the evening. So they can also refer the cases to us, particularly they refer the presumptive cases, symptomatic cases. Sometimes they also diagnosed and then they also refer to us. So the established referring cases, and in cases of any diagnosed cases, would like to go back to the doctors. Our staff also ensure this linkage with the doctors. But in Bangladesh, actually, we haven't started any treatment through the private care providers. So treatment is still under the NTP centers, but they can consult during the whole period of treatment. So that linkage and then connection that we maintain through our staffs. The next part is quite interesting, as Anupama says, just more than 100,000 non-graduate private practitioners is basically a non-qualified one throughout the country, and then engaging them is quite challenging. So we tried much to sensitize them and encourage them to refer, but you have to understand that they also delay sometimes, not referring immediately. So that's the case we have been happening in experience in Bangladesh, delaying these cases, many from this non-qualified one to the main NTP sectors centers or the private qualified doctors. So this is the area that we're struggling on that part. Workplace, we almost established many TB centers in many workplaces, but we also have a mobile van moving those workplaces along with this, prisons that I was talking about. So workplace was a good coverages, and many of the workplaces very good, even in health facilities are there. So we do establish connections through the major manufacturer associations. So we have a agreement with this, garments industries associations, knitwear industry associations, leather associations. So we basically connect these industries through the associations and ensure that their workers are being tested, and if they're patients, they will get the treatment free from the NTP. So these are the basic 5 workable model. We see the private sector engagement. We don't see till now the NGOs as a private sector, because that's kind of a part of the NGO, the NTP services, but provided through the private NGOs. So that's why we didn't cover it. This goes mostly with the community-based interventions. While doing it, we also see this. If you have the rapid diagnostic test kits in TB diagnostic centers, you might have a better access to care from the private providers. So they also prefer to sending this facilities if they have a more molecular test, new diagnostics, all this available. So that's the kind of way that you can attract more private care providers to sending here free of cost for diagnosis. The another part of this interest. Yes.
Can you move a little faster? We are actually at the end of our time, but
okay.
I'm just giving you a notice. Thank you.
Okay. I'm going. So the facility-based care is again in the hospital. So in hospital, basically we do a kind of a screening and the report back directly to the system, and we also do the online reporting system for X-ray. I will not go more detail, but what I'm going to say here, we don't see PPM in Bangladesh as a standalone interventions. We see PPM as a part of the entire TB system, TB ecosystem. So that is why maybe some differences between the other countries that we have in Bangladesh. And so I will not go more details. So our diagnostic facilities with the dedicated supports are being linked up with the different tiers, the different facilities with the public and the private. So that's maybe the beauty of the Bangladesh having, one is community system, one is the private sectors, but both systems are being in the total NTP ecosystem is linked up. So maybe I will share the presentation. You can see more details. So that's the key part of our design. Anupama, shared this slide, so I'm just going to, drop these slides. That's sort of why I'm saying that about 50% cases are coming from the NGO sectors, around 20% from the private for-profit. So NGO sectors mostly, classified as a community-based care because that's mostly coming from the community health workers referral mechanism. Yeah, so going forward, Anupama also highlighted some of the challenges that we have it, in the private sector, particularly. This one is area in low coverage or engagement, inadequate diagnostic facilities in these private sectors. Another area that she was also talking on the Jana web, but I think that's a very limited access. And it's, so that needs to be worked again. And then ACF is not available in the mostly private sectors. And quality of care is a concern because there's mostly private care facilities they diagnose through the X-rays. So this is the basic major challenge we see at this point. So mandatory notifications, quality of the care, this diagnostic facilities in the private sectors, and then low connectivity with the private care providers. Still, there is a big gap in, yeah. So I will not be, using this slide much as I talked about the challenges. So we are planning to have some, improve our system for decentralizing this, the review process on the private sector engagement and the results. So with both government and NGO participation, we plan to have expand non-graduate private practitioners, but we really need to a little bit carefully because the numbers is quite huge. But we'll certainly will be expand our diagnostics supports and the GPP graduate practice engagement in the next phase of application, and also the DORS corner will be expanded in the many private hospitals, which is not much, which is not covered yet. So these are the 3 areas we have been covering, and then non-NGPP we may not have a big push in the next phase of application. SCF will be expanding in hospital settings. Diagnostic capacity. If we have more digital X-rays and then also molecular tests available throughout the country, we could have access, improving the access to the new technologies. And of course, we'll strengthen our workplace model. But another thing that's very interesting is that we also need to think about some incentives or enable a system for the private care providers for reportings. Why they will report back, and then apps is still not much friendly to the private providers. That's why is a limited uptake of using this app, and mostly in the large cities in Dhaka. So we really need to work on that side. In the next application, as I talked with you, so we will be mostly focused on in the large cities, towns, and as because of this rapid urbanization. So this will be PPM will be expanded through the diagnostic centers. We'll have a DORS corners in the last hospitals because the many private hospital doesn't have the DORS corner here. So we will increase those in the next application. We'll also increase connectivity with the private qualified providers, especially the low income settings and the mid-level diagnostics and treatment facilities, which is not much covered yet well. So these are the few things we have been planned for in the next application immediately. And then finally, the facility-based ACF expansion in the large hospitals. So we carefully examine basically in our last couple of months, finalizing the strategy and the gaps, and prioritize some activities that will be fit in immediately in the next application. Maybe some of this will be a bit longer term plan, or maybe a more investment needed in the future. So I think I'm done, I believe. Yeah, thank you. So I know that my time is limited.
That was a fantastic presentation and really great to see your responses and the wonderful work that BRAC is doing. So I'm seeing we are at 5 minutes over our planned time already, and clearly there is so much happening that an hour planning to present both countries is very ambitious and didn't really work. But I appreciate that people have a lot of questions, and I see that there are several good questions in the chat. I'm hoping that Dr. Akram and Anupama can answer some of these questions. I would like to also acknowledge that Liza Kimbo was at the Bangladesh joint monitoring mission as well, and I would like to ask her if she would maybe add 1 or 2 comments based on the presentation in Bangladesh, and having looked at the Q&A, if there's anything that you want to highlight what has come forward, Liza. And I'm just kind of giving you a chance here, and if you don't want to chime in, that's also fine.
Oh, that is fine. Thank you very much, Petra, and greetings to Dr. Islam and everyone else. No, it's I think it was all good. I was noting a comment about incentives, and we really support the potential expansion with pharmacies, good work that they're doing, and that the program that we saw with Damien Foundation was providing some incentives to pharmacies. So we saw just a lot of individual pharmacies, but also the pharmacies under the Blue Star and other networks, and recognized their real potential. But scaling up of these models is certainly a challenge for various reasons, and that is something that we'll continue to work with countries to look at solutions. Thank you.
Thank you, Liza.
Presentations. Well, thanks.
I want to thank all the presenters. This was some excellent input on Pakistan and on Bangladesh. Really insightful to hear what the joint reviews have brought forward, and very good to hear what the country programs are planning in response. Thank you to Anupama, to Akramul, to Aamna, to Guy, to Liza, to everyone who has been providing input into this webinar. We will take the different questions that people have asked, and I will put a little document on our TBPPM Learning Network with questions and answers. All the presentations will also be available in a PDF format online, so people can download and look at more details. You will also be able to contact the different speakers through the Learning Network, because they're all members of the Learning Network. So if you have any specific question afterwards, please join the community and ask your questions. We will also probably bring some of these questions forward in a Friday forum, so you can see them again. And with that, I would like to just pop up a small poll for people to give us some feedback. And I would like to thank everyone who has been working behind the scenes to make this webinar possible. So please take your time to answer some of these questions. Thanks so much to the speakers. I am looking forward to collaborating with all of you on future discussions. Wonderful work in Pakistan and Bangladesh. Very great to see it.
Thank you.
We have a webinar next week, which is going to look at the 146 campaign, which is looking at new regimens for TB. And especially, we're going to be talking with a panel of private providers to see how we can make these new TB regimens more available for private providers. If you're interested in that discussion, just register and join us next Friday, 3rd February. And otherwise, have a look on our website, where there will be many other events coming up. Looking forward to seeing everyone online. And with that, I would like to thank everyone. Happy evening for all of you, and happy day and happy rest of the week for everyone else around the world. Thank you for